everybody. Good to see some old friends and new. I'm going to be talking about Medicare, not Medicaid, and I hope I'm not talking about snow and igloos to Eskimos. I'm going to begin with some background because I think it would be helpful to get us all on the same page and then talk a little bit about some of the issues and options that are coming up in the current debate. So to step back, I always like to talk about the people who are covered by the program because that's kind of why we all care so much about the program. It's the family members, it's us at some point in our lives. There are 48 million people who are covered by Medicare. And Medicare exists today because back in the 1960s and before then, half of all seniors lacked health insurance. They could not get health insurance. And I think it's really important to remember that when you wonder why Medicare, why do we need this program? People who are older tend to have, as you can see on this exhibit, many health problems, many are in fair poor health, they have chronic conditions. They're not exactly a favorite group of people for the private insurance market because they do have so many illnesses and conditions. When you think about the 48 million people on Medicare, we often think about seniors because seniors are the majority of the Medicare population. But there are also 8 million people who are under 65 with permanent disabilities who come on because they qualify for Social Security disability payments. And after 2 years, they ultimately get Medicare. So as you're thinking about this program, you want to think, how do the changes that are being talked about not only affect seniors, but also affect people with disabilities who would also have great difficulty finding coverage if it were not for Medicare? As I look at the Medicare population, one of the things I like to keep in mind is the share of the total that has a cognitive impairment. Because and as you see here, some 89% of people have some sort of cognitive or mental impairment. And that's really important when you think about what are our expectations of people on Medicare. Can people age onto the program and have the system essentially work for them? Or are there requirements that we would impose upon people on Medicare that they, at least by themselves and without the help of family members, may not be able to handle because they have limitations? They either have a serious mental condition, they may have Alzheimer's, they may have a more moderate impairment that means they can't manage their bills or take their medications, and that's a big chunk of the Medicare population today. Larry talked about people who are dually eligible for Medicare and Medicaid, and that's kind of the intersection of the programs that I'm talking about and Howard will be talking about. I think we could spend hours, and I won't, just on that population, the 9 million people who are the sickest, the poorest, the highest users, and the most expensive segment of the Medicare and Medicaid populations. And they are, I don't know if they're the low-hanging fruit, because it's not so easy to manage and coordinate care. There are challenges, but they certainly are the group of people who need further attention. Not just from a cost point of view, but in terms of just making the system work better for them. As you think about the Medicare population and you look at images and TV, and you look at magazines, you often get this picture of a pretty wealthy population, an affluent population. And we were kind of interested in this because so many of the proposals that you hear about say, well, let's have the affluent pay more, the affluent elderly. So we wanted to say, well, how rich are they really? And that's what we did. And we worked with researchers at the Urban Institute who produce data for the Social Security Administration. And we were actually a bit surprised by what we found. Half of all people on Medicare have incomes from all sources of less than $22,000. That's above the poverty level. Consider it's double the poverty level. It's half of the Medicare population. But yes, it's true. Less than 1% have incomes over $250,000. So you have what researchers call a skewed population. A small share have a lot of money, and most have modest incomes. Most, as you may know, rely on Social Security for the bulk of their income, and average Social Security payments were about $12,000 this year. How about assets? Because a lot of people say, well, okay, they don't have income, but they probably have a lot of money saved up over their working years, so that when they retire, they've got a nest egg to take care of them. So we took a look at that. Half of all people on Medicare have retirement accounts, like an IRA. Most have other financial assets, like a savings account, like stocks and bonds. But when you dig a little deeper and you say, well, what do you have in there? Half have less than about $2,100 in their retirement savings accounts, half have less than $31,000 in other retirement accounts, and half, when you put it all together, have less than $53,000 in combined savings. And you just heard Larry say that 1 year in a nursing home is $74,000 this year. So is $53,000 a lot of money? I don't know. It is something. It is a nest egg. Would it make me feel comfortable to retire with that amount, knowing what Medicare doesn't cover and knowing what I would be up against if I should need long-term care, which most of us ultimately do? I don't know. But yes, 5% have more than $1 million in retirement assets and financial assets. So again, yes, there are the so-called greedy geezers maybe, or the wealthy golfers, or whatever image you may have in mind, but they are a small subset of the total population. And looking to the future, if you take a look at what the Medicare population will look like in 2030, the picture is not much different. Yes, there will be some growth, but most of the growth is with a small segment of the Medicare population. So you see gains in income and assets among people with higher levels of education, and whites as opposed to blacks and Hispanics. And I just want to make the point here, the red bar on the left is at the average income that we talked about, but there are real disparities by race and ethnicity. Average income among whites is a little bit more than $23,000. That's median income, but significantly lower for Black and Hispanic beneficiaries. You can see that half of all Black and Hispanic beneficiaries have less than about $14,000 in income. Think about that. For all of us here in the room who are working and have an income, think about what that means. There are also disparities by age and marital status, and I'm not pushing marriage, but as you can see here, you do a little bit better if you're married than if you're not. So I want to back up really quickly so we can get on to kind of what's more newsy and just go through the basics ever so quickly because I was asked to do that. I just want to run through the ABCs and Ds of Medicare because you've probably heard of them. Medicare is divided into parts. Part A is mainly inpatient care, mainly hospital care. When you hear about the hospital trust fund or the Part A trust fund, that's Part A, and it's funded by the payroll tax that we all contribute to, the 1.45% that you see go into Medicare. That's the trust fund. Part B is outpatient services like physician, outpatient hospital services, diagnostic tests. That's funded by premiums that people in Medicare pay, and general revenues, taxpayer dollars. Part D, I'm skipping over C intentionally, is the drug benefit, also funded by premiums and general revenues. And backing up to Part C, that's actually all of Medicare benefits, but it's delivered through Medicare HMOs and other private plans. Medicare provides essential benefits, but as I think we all know, it doesn't cover everything. It doesn't cover dental, vision. There's no out-of-pocket limit, unlike most employer plans, and has high cost-sharing requirements. So most people have supplemental coverage from different sources. In employer plans, the blue segment is still the primary source, but employer coverage is eroding. So many of us in this room who are not yet on Medicare may not have employer coverage. And really, this is why younger people need to be thinking about Medicare, because Medicare works in part because people have supplemental coverage. And when supplemental coverage is no longer available to them, Medicare is really where it's at. It's all they have. And so as supplemental coverage erodes, Medicare becomes more important. Medicaid, the program that supplements coverage for the lowest income population, is incredibly essential. And then there's private insurance to fill in the gaps. So with these out-of-pocket costs, the question is how much of a burden is healthcare on seniors today? And what you can see here is the burden of healthcare is significantly greater for Medicare households than for younger households. Older Medicare households are spending 15% of their household budget on health expenses, if you take everything, long-term care, premiums. I think people tend to forget that just as we get older, we still have rent, we still have mortgages, we still have transportation costs, we still have housing, housing's a big one, and we still need to eat. And healthcare takes a bigger chunk because people's insurance costs rise, premiums are rising, we get sicker, we use more services. That compares to 5% for non-elderly households. And when you look at it as a share of your income, what you can see is on average, this is in here, on average, older people on Medicare are paying 16% of their incomes. That's a median. But at the highest end, 1/4 of all people on Medicare pay 30% or more of their income on health care. So health care today, before deficit reduction discussions, before changes to the program, health care today takes a big bite out of many Medicare beneficiaries' income.